Welcome to The Explainer. Today we're diving into something pretty critical, a big shift in how we train surgeons for some of the most high-stakes operations you can imagine. And we're asking a tough question. Is the next generation going to be ready for the absolute worst-case scenarios? I mean, think about it. How do we really know when a surgeon is ready to operate all on their own? It sounds like a simple question, right? But the answer is anything but. Especially now, with technology just completely transforming the operating room at a dizzying pace. Okay, so to really get a grip on this challenge, we've got to start with the basics. We need to look at the body's main superhighway for blood. That's the aorta, and the two totally different ways surgeons can fix it when things go south. So you've got two options. On one hand, there's the classic open surgery. For a long, long time, this was the only way. It's kind of like shutting down the whole highway, digging up the road, and fixing the problem directly. It's invasive for sure, but it gets the job done. But now, you've got the modern approach, endovascular surgery. This is way less invasive. Think of it like sending tiny robotic machines through tunnels under the highway to fix it from the inside, all without ever stopping traffic. And these days, this newer technique is becoming the go-to for a lot of these repairs. And here's where the problem starts to creep in. Because these new, slicker endovascular procedures are getting so common, the surgical trainees of today, well, they're just not getting as much hands-on practice with that old-school, classic open surgery. The chances to really learn it in a live setting, they're just drying up. So what happens when a patient comes in, maybe in an emergency, and they need that classic open repair? What happens if the next generation of surgeons just hasn't had enough reps? That is the million-dollar question, and it's exactly what a new study set out to answer. They wanted to figure out a way to actually measure how ready these trainees are. Okay, so how did they do it? Well, to get real hard data, the researchers knew they couldn't just count up how many surgeries a trainee had done. No, they needed something better. They used a pretty cool modern tool to grade surgeons right there in the moment, like literally seconds after the operation finished. It's called SIMPL, which stands for Society for Improving Medical Professional Learning. Basically, it's a smartphone app. Think of it as a real-time report card for the operating room. It lets the senior, expert surgeon who's supervising give immediate, direct feedback on how the trainee did. No waiting, just right then and there assessment. And the process is pretty straightforward, but really, really smart. The trainee does the surgery, supervised, of course. Then, bam, right after, the supervising surgeon opens the SIMPL app and rates their performance and how much help they needed. But here's the key part. The trainee also does a self-assessment on the app. So for every single procedure, you get these two incredibly valuable data points, what the expert thinks and what the trainee thinks they did. And you should know, this was no small-time study. We're talking about a huge national effort. They looked at 54 trainees, 50 faculty surgeons across 19 different training programs. All told, they crunched the numbers on 579 assessments over 5 years. So yeah, this gives us a really solid big picture look at what's happening across the country. All right, so this is where it gets really interesting. They've got all this data. What did it actually show when they compared the old school open surgery with the new endovascular techniques? Let's just say the results were, well, they were pretty stark. Okay, here it is, the absolute core finding of the whole study. By the time they reached their final year of training, these surgeons were rated as practice-ready in about half of the modern endovascular cases they did. That's pretty good. But for the classic open repairs, wow, that number just falls off a cliff, down to just 22.2%. Let me put that another way for you, because it's a big deal. When they ran all the numbers, the stats showed that a graduating trainee was 4 times less likely to be considered proficient in open surgery compared to endovascular surgery. 4 times. That's a massive difference. But wait, it gets even more complicated. Remember how the trainees were also rating themselves? This is where a fascinating psychological wrinkle pops up. When it came to that classic open surgery, the trainees consistently rated their own skills way higher than their supervising mentors did. So what does that mean? It's a huge deal. It suggests that there isn't just a skills gap here, there's also an awareness gap. The trainees themselves might not even realize where their skills are lacking. They could be heading out into practice, feeling a lot more confident about handling these super complex open cases than they really should be. Okay, so it's easy to look at this and feel a little worried. But the great thing about this research is that it doesn't just point out a problem and walk away. It actually starts pointing us towards some real, tangible solutions. So what's the path forward?
Well, the experts are talking about a three-pronged attack, really. First, using incredible technology like super high-fidelity 3D printed models of the aorta so trainees can practice these tough open procedures over and over in a totally safe environment. Second, creating what you might call super fellowships, extra super focused training for surgeons who want to master these advanced techniques. And third, and this one's so important, really doubling down on mentorship from experienced surgeons, especially when a new surgeon is just starting their career.
And at the end of the day, you have to remember why all this matters so much. This isn't just some academic debate about the best way to train people. This is about patient safety, plain and simple. It's about making absolutely sure that no matter what kind of surgery a patient needs, the newfangled one or the old school life or death one, the person holding the scalpel is 100% ready to go. And that really leaves us with a huge looming question. And it's not just for surgery. It's for, well, for almost any high-stakes job in our world that's changing so fast. In an era of non-stop innovation, how do we make sure we're training for the skills we might use less often, but are the ones we need the most when everything is on the line?